Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. This is going to be our first microbiology lecture for the respiratory system module, and it's going to be about the respiratory tract infections. So to start off, we're going to talk about the anatomy of the respiratory system. So the respiratory system or the respiratory tract is a major portal of entry for infectious organisms. And it is divided into three tracts: upper, middle, and lower. And in other resources, we can find that the respiratory tract is divided into upper and lower divisions only. So the divisions are based on the structure and function of each part. The three parts have different types of infections. So the upper respiratory tract includes the mouth, nasal cavity, sinuses, and pharynx. And infections are fairly common in the upper respiratory tract, usually nothing more than an irritation. The middle respiratory tract includes the epiglottis, larynx, trachea, bronchi, and bronchiole, and most of the infections in the middle respiratory tract is caused by viruses. Also, we have the lower respiratory tract, which includes the lung and the alveoli, and infection in this part of the respiratory tract is called pneumonia. And the infections are more dangerous since the lower respiratory tract is a sterile environment in comparison to the upper respiratory tract, which has normal flora or microbiota which occupy the upper respiratory tract. And the lower respiratory tract infections might be difficult to treat. So if we want to talk about the other way to classify or to divide the respiratory system, upper and lower. So the upper include the mouth, nasal cavity, sinuses, pharynx, epiglottis, and the part of the larynx above the vocal cord. The part of the larynx which is below the vocal cord, trachea, bronchi, bronchioles, lungs, and alveoli are all considered within the lower respiratory tract. So the most accessible system in the body is the respiratory system because we breathe directly into the lungs, and this could have potential infectious pathogens within the air that we breathe. But the body has a variety of host defense mechanisms to defend the body against the pathogens which might be present in the air. So we have the innate immune response and adaptive immune response. Innate immunity or non-specific immunity, and we have the adaptive immunity or the specific immunity. Upper respiratory tract is continuously exposed to potential pathogens. And what are the defense mechanisms that we have in the upper respiratory tract? We have the nasal hair, we have the mucus within the upper respiratory tract, which can trap the pathogens. Also, we have the humoral part of the immune system, which is the IgA antibodies, which are present in the secretions or in the mucus within the upper respiratory tract, and which can defend the upper respiratory or the respiratory tract against invading pathogens. Lower respiratory tract is essentially a sterile environment. As we said, the lower respiratory tract is a sterile environment. The upper respiratory tract is not a sterile environment. We have some microbiota or normal flora which live in there, which lives there in harmony with the human body. Mostly does not cause harm or infections for the carriers of these microbiota or normal flora, but they can transmit it to others once they get into contact with them. And we're going to talk about the types of normal flora or microbiota present in the upper respiratory tract in the coming slides. So the normal flora of the respiratory tract generally limited to the upper respiratory tract, mostly composed of the gram-positive bacteria, streptococci and staphylococci. These are the most common normal flora which are present in the oral and nasal cavities. Disease-causing bacteria are present as normal flora and can cause disease if their host becomes immunocompromised or if they are transferred to other hosts. So it's living in harmony with the human body. If the person becomes ill or immunocompromised or takes drugs that compromise the immune system, or he becomes chronically ill, such as infected with HIV, cancer, taking anti-cancerous agents, so he might become more prone to infections with these normal flora. Also, patients who have these normal flora living in harmony with his body can be infectious to others when he gets into contact with them. So he's a silent carrier of these normal flora or microbiota. Once again, what are the types? We have the Streptococcus pyogenes, we have the Haemophilus influenza, Streptococcus pneumonia, we have the Neisseria meningitis, and we have the Staphylococcus aureus. And these are present in 5 to 30% depending on the type of the microorganism or the bacteria. From 5 to 30% of the adults might be having these normal flora within the oral cavity and the nasal mucosa. Once again, to continue with the bacterial flora in the normal person in the community, mostly it is caused by the Staphylococcus species, Streptococcus species, especially Streptococcus pneumoniae, or the alpha hemolytic Streptococcus. Also, the group A beta hemolytic, which is the strep pyogenes, also can be part of the normal flora. The Haemophilus influenza, the non-typable Haemophilus influenza, and anaerobes. Patients who get admitted into the hospital or to the intensive care units for a period more than 3-4 days, then the type of normal flora might change and shift to other types of normal flora, such as the Staphylococcus species, anaerobes. Also, E. coli, Klebsiella, Candida, and Pseudomonas become more likely to occupy the respiratory system, the upper respiratory tract, and thus patients who are admitted to the intensive care unit might require shift of the antibiotic to be more broader spectrum antibiotic if they are within the intensive care unit or in the hospital setting or on a ventilator for more than 4 days, because there is a shift of the normal flora into these types. Once again, what are the defenses within the respiratory tract? We have the nasal hair, we have the ciliary escalators, cilia, which are present in the respiratory tract and which clears the air passages unconsciously. And if we get infected with mostly viruses are going to lead to killing of these cilia, and as a result of that, the respiratory tract is going to lose an essential and an important part of the defense mechanism. But the body has another way to compensate for this loss, and this is going to be through the coughing. So it's going to the body is going to respond to the loss of cilia by activating the coughing reflex in order to keep clearing the airways. Also, we have the involuntary response such as coughing and sneezing, and we have the IgA antibody, which is present in the secretions. In the lower respiratory tract, we have also the mucus, we have the alveolar macrophages, and we have the secretory IgA as well. Mostly we said the normal flora is composed of the strep biogens, Streptococcus pneumonia, Haemophilus influenza, non-typable Haemophilus influenza, Neisseria meningitis, and Staphylococcus aureus, and they are all considered as part of the normal flora or normal biota or microbiota. The lower respiratory tract does not have any normal flora, and it is a sterile environment. To a lesser extent, we might find the Moraxella catarrhalis, the non-hemolytic and alpha-hemolytic streptococci, Corynebacterium and other diphtheroids, and the Candida albicans to be as a normal microbiota. But mostly these are the normal microbiota within the upper respiratory tract. So we have multiple bacterial, viral, fungal, and parasitic infections that can infect the respiratory tract. It represents a portal of entry for the viral pathogens, and vaccination has proven to be very effective in combating and eliminating many of these respiratory infectious agents. Most of the world who had established a good vaccination program, national vaccination program, they have reduced dramatically the number of respiratory tract infection caused by these common respiratory tract pathogens. There are still some parts of the world, the underdeveloped parts of the world, where they lack the resources and they lack the money to establish a strong vaccination program, and even people do not have access. If they had that vaccination program, they do not have access to it easily. So in this part of the world, we still hear about these respiratory tract infections as a cause of respiratory tracts. Pathogens of the respiratory system. Respiratory pathogens are easily transmitted from human to human. They circulate within a community and the infections spread rapidly. And if we want to give an example, these days we're living in a pandemic which is caused by COVID-19, and this is a virus, one of the viruses that causes upper respiratory tract or even lower respiratory tract infection in immunocompromised, in old age, and in those who are susceptible and more prone to the infection with the virus, who have chronic illnesses. We know that it circulates within a community and the infections spread easily, especially with the new variants that are emerging every now and then. Some respiratory pathogens exist as part of the normal flora. We've already talked about that. Others are acquired from animal sources. We call them zoonotic infections. Zoonotic infections are infections where the infectious agent is transmitted to humans from animals. So when we talk about Q fever, it comes from farm animals. When we talk about psittacosis, which comes from parrots and other birds, and in this case the bacteria is transmitted from these birds or parrots to the humans and cause lower respiratory tract infection. So this is the zoonotic infection from animal to human. Also water, the water system can be a source of respiratory infection. And when we talk about water system, we talk about central ACs, the air conditioners. These central air conditioners might play a role in spreading infections if the water within these systems is contaminated with this type of bacteria, then it's going to be aerosolized and it's going to be inhaled by the humans, and it's going to spread the infection. One of them is the Legionella, which causes legionellosis, which can be transmitted via the central air conditioning systems. Fungal infections also can, or fungi also can infect the upper respiratory tract or even the lower respiratory tract, but this is very rarely seen in immunocompetent person. It is usually seen in immunocompromised patients. And fungal infections are most dangerous when they are caused by Aspergillus fumigatus or Pneumocystis jirovecii. And as we said, these are more seen in immunocompromised patients. So for example, Pneumocystis jirovecii is usually seen in HIV infected patients. Some pathogens are restricted to certain sites, like the Legionella only infects the lungs, but we have other pathogens that can infect multiple sites, such as Streptococcus pneumoniae. Streptococcus pneumoniae might infect the middle ear, might infect the sinuses, or it might infect the lower respiratory tract, leading to pneumonia as well. So the defenses of the respiratory system, we've already talked about that. Just another reminder, we have in the upper respiratory tract, we have the mucociliary escalator, and we have the coughing reflex, the sneezing reflex. Also, we have the secretory IgA. The lower respiratory tract, we have the alveolar macrophages, and we have the secretory IgA, which can interact with the invading microorganisms. So defenses of the respiratory system, once again, we have the mucociliary escalator, which can trap debris and bacteria and get it out of the respiratory system. We have the alveolar macrophages, and also we have the muscles of the chest wall and the diaphragm, which can generate cough, which can lead to clearing of the secretions from the upper respiratory tract. These defense mechanisms might be inhibited by viral infection, which can disrupt the function of the respiratory epithelium. As we said, if virus infection occurs, it might lead to death of the cilia within the respiratory tract, and as a result, this mucociliary escalator function is going to be lost, but it is going to be compensated for by coughing, and usually it takes 6 to 12 weeks for the mucociliary escalator to get back to the fully functional status seen before the infection. A bronchial carcinoma can obstruct the bronchus, and infection can arise behind the obstruction. So if the obstruction occurs here, then most likely infection might occur in the point after the obstruction because the functions, the normal functions of the lung are going to be depleted, and this is going to lead to loss of the ability of the lung to clear the invading microorganisms, and even if treated, it's going to be affected as well. Also, trauma or abdominal surgery can affect the ability of the coughing, and this might lead to inhibition of the defense mechanism. So this is just a tree to show you the types of the bacteria that infect the humans, and we have them divided into cocci, bacilli, spiral, and others or miscellaneous. So if we want to know the gram-positive bacteria, the gram-positive bacteria are divided into cocci and bacilli. The cocci, we have the staphylococcus, and we have the streptococcus, and we have the enterococcus. The gram-negative, we have the anaerobic, and we have the aerobic. The aerobic, we have the non-spore forming and the spore forming. So the non-spore forming, we have the Corynebacterium diphtheriae. The spore forming, we have the Bacillus species and the Clostridium species. And the Bacillus, we have two types. We have the Anthracis and we have the Cirrus. The Clostridium, we have the Perfringens, Tetani, Botulinum. So this is just a quick reminder for you about the bacterial causes of infection in humans. We're going to be talking about the staph, the strep. We're going to be talking about the Corynebacterium. We're going to talk about the Bacillus anthracis. We're going to cover what else? We're going to cover the Mycoplasma. We're going to talk about chlamydia when we talk about atypical pneumonia. And we're going to talk about the Mycobacterium when we talk about the AFP or the acid-fast bacilli. We're going to talk about Mycobacterium tuberculosis to be more specific. So these are the major bacteria that we're going to cover in the respiratory system. Bacteria infecting the respiratory system can be divided into groups depending on the infection that they cause, such as those which cause otitis media, sinusitis, mastoiditis, those which cause pharyngitis. Also, in the lower respiratory tract infection, we're going to have, there are multiple ways of classifying pneumonia. One of them is typical and atypical pneumonia. Community acquired and hospital acquired pneumonia is another way of classifying the pneumonia. And based on the location of pneumonia, we have the lobar pneumonia, segmental pneumonia, interstitial pneumonia. This is a third type of classification of pneumonia. We're going to talk about pneumonia, and we're going to talk about all these types of classification for pneumonia. Upper respiratory tract disease caused by microorganisms. We're going to talk about first the rhinitis or the common cold. So rhinitis, from its name, rhine, which has to do with the nose. Itis is infection of the nose, which is going to lead to inflammation as well. So another name for rhinitis is common cold. Common cold, all of us have experienced common cold, and the symptoms are sneezing, sore throat, runny nose, which is the most common symptom of rhinitis and common cold. Symptoms usually begin 2 to 3 days after infection, so it's characterized by a short incubation period, usually not accompanied by fever, and it eventually leads to nasal obstruction and nasal discharge. Causative agents are mostly viruses, and here we're talking about rhinovirus and coronavirus as the most common viruses, or the common cold viruses. We call them common cold viruses, which are the rhinovirus and coronaviruses. And when we talk about coronaviruses, we're not talking about COVID-19. So coronavirus has been known long ago, since the 1960s, to cause mild upper respiratory tract infection, in addition to the rhinoviruses, and most of the common cold are caused by those two, rhinoviruses and coronavirus. Also, we have the adenovirus, we have the parainfluenza, influenza virus, and respiratory syncytial virus also can cause common cold in adults and children. Common cold is rarely caused by bacteria or fungi. The second type of upper respiratory tract infection is pharyngitis. And pharyngitis is the inflammation of the throat, which is characterized by pain, swelling, redness of the mucosa, swollen tonsils, and sometimes we might see white packets of inflammatory products, or white dots or white patches of exudate on the tonsils and on the pharynx, and sometimes we might even be able to see petechial hemorrhage or pinpoint hemorrhages, dots, red dots, which indicate very small points of hemorrhages. The mucous membranes may swell, and this might lead to impairment of the speech and swallowing. This is more often seen in children than adults. Also, this might be accompanied by foul-smelling breath, and the incubation period is also short, from 2 to 5 days. Differential diagnosis of follicular tonsillitis. When we say follicular tonsillitis, then we're talking about the type of follicular tonsillitis or pharyngitis, type of infection which is caused by bacteria. Follicular meaning that there is an exudate. So there is these white packets or white patches or white dots which represents exudate, and these are caused by bacteria. Most common bacteria to cause follicular tonsillitis is group A beta hemolytic strep, which is strep biogens. The differential diagnosis, when we say differential diagnosis, when I ask you to come up with a list of differential diagnosis in this case, so we've diagnosed that patient that he has pharyngitis. But the list of differential diagnosis, when I ask you to come up with a list of differential diagnosis, then what are the most common pathogens that can lead to this clinical picture of exudative pharyngitis or follicular pharyngitis or tonsillitis? Number one, more than 90 to 95%, it is caused by strep biogens. Could it be caused by viruses? Most probably no. If it's exudative, no. But is there an exception? Yes, there is an exception, which is the adenovirus. Adenovirus infection we might see some exudative material on the pharynx or on the tonsils. What about Candida albicans fungal infection? Candida is characterized by forming a whitish coating over the tonsils or the pharynx. As we said, Candida albicans is mostly seen in immunocompromised patients. So if you have pharyngitis in an immunocompromised, you must think of Candida albicans as the cause. So the list of differential is strep biogens on top of the list, followed by adenoviral infection. Another virus, Epstein-Barr virus, also might come as exudative pharyngitis, and Candida albicans. So if we look at this picture, this patient has enlarged tonsils, as you can see, edematous and reddish pharynx and tonsils. Also, you have those white exudative patches on the tonsils, which are indicative of mostly bacterial tonsillitis or pharyngitis. Those two figures are used to differentiate between bacterial and viral infections. So in the case of bacterial infection, we can see redness and swelling in the uvula, in the pharynx, in the tonsils, whitish spots, which represents exudative material, red and swollen tonsils, also throat redness, and we can see the gray fairy tongue. And in this case, the patient might present with foul smelling breath as well. In the viral pharyngitis or tonsillitis, we might see the only presentation might be redness and swelling in the pharynx and the tonsils. So the most common mode of transmission is, we have here two causes of pharyngitis: strep pyogenes. 95% of exudative pharyngitis or follicular pharyngitis or tonsillitis is caused by strep pyogenes, and the non-follicular tonsillitis is mostly caused by viruses. Transmission in strep pyogenes is caused by droplet or direct contact. In viruses, droplet, direct contact, using the patient's personal belongings, all forms of contact with the patient might lead to infection with these viruses. There are multiple types of virulent factors that we're going to talk about later on when we talk about strep pyogenes in detail, such as the M protein, hyaluronic acid capsule, and the superantigens. The diagnosis, beta hemolysis on blood agar. So if we grow if we take a swab from the pharynx of the patient and grow it on the blood agar, then the strep pyogenes, if present, is going to lead to beta hemolysis. And what we mean by beta hemolysis is that as a result of a growth of the bacteria on the blood agar, it's going to lead to hemolysis of the blood agar and turn the color of the agar from the reddish into the yellowish, because it's going to degrade or break down the RBCs. Sensitive to bacitracin and can be detected easily by rapid antigen testing, which can be done in the clinic setting and can give a rapid result within 10 to 15 minutes. Diagnosis, it's important, especially in children, to rule out strep pyogenes. If it's not strep pyogenes, then it is virus. It's not really important to know which virus, because viruses usually cause mild infection which require only symptomatic treatment. Why do we need to rule out presence of strep pyogenes? Because if strep pyogenes, the bacteria, is the cause, we must and have to treat with antibiotics. So if the patient or the child presents to your clinic complaining of sore throat, fever, and once you examine him, you've seen follicular tonsillitis or exudative material on the tonsils, they are enlarged, the pharynx is enlarged, red, and the presentation and examination are with follicular tonsillitis, you should treat with antibiotic. If you do not treat with antibiotic and the causative agent is strep biogens, then the child is going to go into complications. We're going to talk about the complications later on, but you should at this stage know that you should treat with antibiotic. Penicillin, cephalexin can be used in case of penicillin allergy. In case of viral infections, treatment is symptomatic treatment. Prevention hygiene practices in both, and the distinct features, generally more severe than viral pharyngitis and exudative tonsillitis, goes always with strep biogens. We said that other microorganisms such as the adenovirus, Epstein-Barr virus might lead to infections which mimic strep biogens infection. And we know that viruses or viral infection should not be treated with antibiotic. So what to do in this case? We said 90 to 95% of the cases with follicular tonsillitis are caused by strep biogens. So there's only a chance of 5 or less % of these infections being caused by viruses or other things. So go ahead and treat with antibiotic, even if it might be caused by the virus. So treating with antibiotic in order to get 95% of the cases which are infected by strep biogens is much better than not giving the antibiotic in order to avoid giving the antibiotic to viral infection. فاهمين نقطتي هون؟ يعني 95% من الكيسز if not more 95 to 97% راح تكون strep biogens. في عنا من 2 إلى 5% ممكن تكون فيروس. الفيروس بنعرف إنه مش لازم إحنا نعطي antibiotic، بس في هاي الحالة الأهم if we have follicular tonsillitis أهم إشي إنك تعطيه antibiotic حتى لو كان شاك إنه viral infection. إذا الكلينيكال بيكتشر ماشي مع strep biogens أو في عنا exudative tonsillitis أعطيه antibiotic. إحنا already أصلا في عنا abuse للantibiotic للأسف معظم الأماكن, and this attitude I want from you as future doctors, and never ever to give an antibiotic for viral infection. If you're 100% sure that this is viral infection, clinical pictures with viral infection, then never prescribe an antibiotic. But if it's follicular tonsillitis, always prescribe an antibiotic. حتى تلقط ال 95 ل 97% من الحالات مش مشكل انك تعطي ل 2-3% من الفيرال انفكشن antibiotic. The third type of infection is the sinusitis. So we have the frontal sinuses, we have the ethmoidal sinus, sphenoidal sinus, and the maxillary sinus. Infection within the sinuses is considered a type of infection in the upper respiratory tract, most commonly caused by either local, can be divided into local and systemic. In the local, upper respiratory tract infection produce edema of the antral tissue, nasal septum deviation, enlarged adenoids, tumor or foreign body in the nasal cavity. Never mind. What's the most common cause of local sinusitis? Is upper respiratory tract infection caused by viruses. So upper respiratory tract infection caused by virus is going to lead to congestion within the nasal cavity and the sinuses. And as a result, because we know that the upper respiratory tract has normal flora. This normal flora is usually present in the oropharynx and the nasal cavity. But once there is upper respiratory tract infection with the viruses, then secretions are going to fill the nasal cavity and the sinuses, and the normal flora is going to go from the nasal cavity into the sinuses and is going to cause infection within the sinuses. Also, we have the systemic, such as allergy during the allergy season in the spring. Also, we have the cystic fibrosis and patients with immunodeficiency. What are the symptoms of sinusitis? Symptoms are usually nasal congestion, pressure above the nose or in the forehead, headache, toothache. We might also feel like facial swelling, and the location of the sinuses, you might feel tenderness. If you try to press on the location of the sinuses, you might feel tenderness, and this could be accompanied with fever, or most of the time fever might be missing. Discharge appears opaque with a green or yellow color in case of bacterial infection. In case of allergy, the color of the discharge is clear, and it's going to be accompanied by itching and watering of the eyes. So if there is itchy eyes and there is watery eyes, then this is most likely with, even if there is redness in the eyes, this might go better with allergy. What are the causative microorganisms in sinusitis? The most common are the strep pneumonia and the Haemophilus influenza. Once again, when we talk about Haemophilus influenza as a causative agent, we have the typable Haemophilus influenza and the non-typable. What's the difference between the typable and non-typable? The non-typable does not have a capsule, while the typable does have a capsule. So which one is the causative agent in sinusitis? It's the non-typable Haemophilus influenza. Could be less commonly caused by strep biogens, Staph aureus, or Moraxella catarrhalis. So diagnosis, gram stain and culture of direct sinus aspirate. Treatment, we have acute. In case of acute sinusitis, then we might need to take a gram stain and culture of the direct sinus aspirate and send it to the lab. But during this period, we should not wait. We should start the patient on empirical antibiotic therapy. What do we mean by empirical antibiotic therapy? We mean by starting the patient on broad spectrum antibiotic until the stain and culture results and sensitivity come back, and then once we get them back, we might need to shift the patient onto a lower spectrum antibiotic according to the sensitivity testing. If we have chronic or complicated sinusitis, we need to obtain cultures and determine the antibiotic sensitivity of the causative microorganism. Otitis externa can be caused by local trauma to the outer ear, furunculosis, which is infection of the hair follicle. So infection in the origin of the hair follicle, mostly caused by Staph epidermidis, Staphylococcus epidermidis, or Staphylococcus aureus, and It's a lesion within the hair follicle where there is exudate. Also, foreign body and excessive moisture can lead to otitis externa, swimmer's ear. Symptoms are characterized by pain and redness. If we have malignant otitis externa, it could be, it's most likely caused by Pseudomonas aeruginosa. Diagnosis through clinical examination and treatment through topical antibiotics. Also, we have the acute otitis media, middle ear infection. It is a common sequelae of rhinitis or common cold or upper respiratory tract infection, mostly caused by viruses. So viral infection of the upper respiratory tract lead to inflammation of the eustachian tube. And it leads to buildup of fluid in the nasal cavity and in the middle ear, which can lead to bacterial multiplication in the fluid. So, you remember when we talked about the sinusitis, the same occurs here. Then nasal congestion, also due to the proximity of the eustachian tube to the oral and nasal cavities, then these secretions might reach the eustachian tube, and as a result of upper respiratory tract infection, the eustachian tube might be inflamed and edematous. And in the presence of the secretion, this might lead to obstruction of the eustachian tube. تحس إذنك زي كأنها إيش؟ مسكرة وأنت مرشح. But the middle ear and inner ear still needs to breathe, still needs oxygen to breathe. And in case the eustachian tube is edematous and it's blocked by the secretions, then the middle and inner ear are going to use the oxygen which is present in the space within the inner and middle ear. And once they consume or use this oxygen, this is going to make a negative pressure-like mechanism, which is going to withdraw the secretions into the middle ear as a result. بالميدل اير والانر اير بيحتاجوا اكسجين. الاكسجين راح يكون موجود في الكافيتي of the middle and inner ear. Once these organs are going to use the oxygen, راح تاخذه من الكافيتي اللي هي filled with the air. هذا الحكي شو راح يعمل؟ راح يعمل عملية تفريغ أو جذب للسكريشنز within the edematous eustachian tube وتسحبها لوين؟ للميدل اير. secretions شو فيها؟ فيها النورمال فلورا اللي موجودة في النيزل cavities. وبالتالي this leads us to the causative organisms of otitis media. في الأطفال اللي أكثر من 3 شهور والadults most commonly are caused by strep pneumonia and Haemophilus influenza. Once again, when we talk about Haemophilus influenza, we're talking about the non-typable. So they are the same causative organisms like in the sinusitis. هذول اللي هم part of the normal flora. Less common can be seen in strep biogens, Staph aureus and Moraxella catarrhalis. بما أننا بنحكي عن نفس الميكانيزم sinusitis and otitis media, then the causative microorganisms are the same in the adults. In children less than 3 months, strep pneumonia, a group B strep, which can be acquired from the mother, Staph aureus and Pseudomonas aeruginosa might be causative agents in this case. So the bacteria can migrate along the eustachian tube from the upper respiratory tract, multiply rapidly, lead to pus production and continued fluid secretion. So خاصة بالأطفال، إذا الطفل إجانا ب upper respiratory tract infection اللي هو mostly viral، وعالجناه symptomatic لأنه شخصناه إنه viral معناته ما بده antibiotic، وعالجناه symptomatic وأموره تمام، ما كان عليه حرارة، بس كان إيش؟ عنده رشحة قوية، أنفه مسكر، أذانه مسكرة، أموره تمام. بعدها بأسبوع 10 أيام the child started to have fever, he started to have earache, then we should think of otitis media. Symptoms: fever, sensation of fullness or pain in the ear. Treatment: what's the treatment here? Is it symptomatic treatment? No, we should prescribe an antibiotic. We should prescribe an antibiotic to treat otitis media in this case, because untreated or severe infection can lead to eardrum rupture or mastoiditis and might lead to CNS involvement. Even in certain cases, the patient might start to have very severe pain in the ear, and when he comes to you, you might see that there is pus or fluid coming out of the ear. In this case, he's going to have an eardrum rupture. What would you do? You're going to send culture and sensitivity from the secretions which are coming from the ear, and you're going to start him on empirical antibiotic therapy or broad spectrum antibiotic therapy. And you're going to reassure the parents that the eardrum is going to heal. Most of the time it's going to heal normally and without any bad sequelae. So as you can see here, this is a Eustachian tube. It becomes edematous. So you can see that the space in here becomes more narrow, and you can see that this cavity is going to be filled with the secretions, and the cavity here is going to have air, and it's going to use this air in here, take the oxygen from it. As a result of breathing oxygen, this is going to generate negative pressure, which is going to lead to the withdrawal of the secretions from this compartment into the middle ear, and this is going to lead to pressure on the eardrum. This is going to be seen as bulging of the eardrum when we do examination for the ear, and as I said, this pressure might be too strong that it might lead to eardrum rupture and escape of the exudate through the external ear canal. This can be seen frequently in children, but as I told you, the treatment is antibiotic and reassurance of the patient that the eardrum is going to regenerate and close without any sequelae. Strep pneumonia, Haemophilus influenza, non-typable Haemophilus influenza, and we have the other bacteria. Culture, treatment, amoxicillin or amoxicillin clavulanic acid, since amoxicillin is 95 to 99% resistant in 95 to 99% of the Jordanian population, since amoxicillin are used for everything. If you have a headache, they used to prescribe amoxicillin in the clinics and hospitals for any reason. So nowadays, just give the patient amoxicillin with clavulanic acid or cefuroxime. We have also diphtheria. which is caused by Corynebacterium diphtheriae. Symptoms initially experienced in the upper respiratory tract as a sore throat, lack of appetite, and low-grade fever. Corynebacterium diphtheriae infection is associated with the formation of a pseudomembrane in the tonsils or the pharynx, and this pseudomembrane is caused by, so the infection with Corynebacterium diphtheriae, there is a toxin release. This toxin is going to affect the protein synthesis, going to lead to death of the cells which are infected by the bacteria, and this is going to form a cellular debris or dead cells in addition to the pus, the dead bacteria, and it's going to be encased with a membrane-like pseudomembrane, membrane-like أو اللي هو membrane وهمي. Differential diagnosis of pseudomembrane. So if we see this pseudomembrane formation, we should think first of all of Corynebacterium diphtheriae. How common is infection with Corynebacterium diphtheriae? Very, very, very rare, due to the use of the diphtheria toxoid vaccine as part of the DTP, diphtheria, tetanus, pertussis vaccine. Is it part of the national vaccination program in Jordan? Yes, it is. When is it given? It's given beginning of the 3rd month, beginning of the 4th month, beginning of the 5th month, and it's also given preschool and 10th grade. So due to the vaccination, you would never see diphtheria in Jordan, or very, very, very rarely to see diphtheria. Also, we should think of Vincent's angina, and this does not have to do with the heart. Angina here means infection with anaerobic bacteria in the oral cavity, which is called Vincent angina. Also, infection with the Epstein-Barr virus, which might lead to formation of exudative or pseudomembrane-like. Also, Candida albicans, also adenovirus, also strep biogens. All these might lead to formation of pseudomembrane or exudative material within the tonsils or the pharynx. So this is the pseudomembrane formation caused by Corynebacterium diphtheriae. As we said, this is cellular debris with exudate, with the killed bacteria, and with mucin. Diphtheria is caused by Corynebacterium diphtheriae, which is transmitted via droplet contact, direct contact, or indirect contact using contaminated fomites. And what do we mean by fomites? Fomites are the personal belongings of the patient, like his mug, toothbrush, towels. Virulence factors in the diphtheria. We have the exotoxin, which is the diphtheria toxin. Culture and diagnosis, we have the tellurite medium, where we're going to see gray blackish colonies. Prevention of the Corynebacterium diphtheriae is via the DTP vaccine, and treatment, we should always treat the Corynebacterium diphtheriae with the antitoxin plus the antibiotic. Antitoxin plus the antibiotic. Other types of middle or upper respiratory tract infection إذا بدنا نستخدم هذا التصنيف أو هذا التصنيف حرين into acute epiglottitis, laryngitis and croup are considered part of the upper respiratory tract. Tracheitis, bronchitis and bronchiolitis are considered part of the lower respiratory tract, if you want to use the classification of upper and lower. Okay, let's talk about epiglottitis. Acute epiglottitis occurs with an abrupt or sudden onset of throat and neck pain, fever, and inspiratory stridor. Inspiratory stridor. Due to narrowing of the airways, the patient, once he or the child, mostly seen in children, once he wants to take to breathe, then this is going to generate an inspiratory stridor. Which is a sound, an inspiratory sound, high-pitched sound due to narrowing of the airways. Muffled phonation or aphonia and difficulty swallowing or drooling. Muffled phonation or aphonia يعني المريض يا إنه صوته ما في صوت بالمرة أو صوته مش مظبوط معجل. And difficulty swallowing and drooling. من شدة الألم مش قادر يبلع ريقه وبالتالي he's drooling. This is a medical emergency, and in this case, if you suspect acute epiglottitis, you should never use the tongue depressor or the throat swab to examine the patient, because if you use them, you're going to lead to more edema and obstruction of the upper airway. And in this case, if we reach this stage, then the only way to save the patient is doing tracheostomy, is opening into the trachea to allow the patient to take breath from the tracheal opening. Caused mostly by bacteria. 90% caused by bacteria, and 90% of the cases is caused by Haemophilus influenza type B. Here the typable Haemophilus influenza, and it's type B. Less commonly strep pneumonia, Corynebacterium diphtheria, and Neisseria meningitis. Diagnosis via blood culture and the X-ray. If you look here at the X-ray, you're going to see a thumb sign. Thumb sign here. See the arrow? Like a thumb sign. And this is an indication of narrowing of the airway. So treatment, adequate airway, humidified air and oxygen. So in this case, the patient should be admitted to the hospital, and he should be taken care of. He might need to have an airway inserted in order to ensure maintaining the airways open, then giving oxygen and humidified air, and then starting the patient on the antimicrobial therapy against the Haemophilus influenza type B. Laryngitis and croup, sudden onset or a slow onset. We have either sudden onset or slow onset. It is characterized by laryngitis and croup. Laryngitis and croup. Croup is laryngotracheobronchitis. So laryngotracheobronchitis, another name for it is croup. Laryngitis is the infection of the larynx. It is characterized by fever. Once again, there is narrowing of the airway, so we have inspiratory stridor. And you can go and search for the stridor or the different sounds which are seen in the respiratory tract pathology, and you can hear each and every sound of them, like the stridor, wheezes, crackles. Also in the patient we can see hoarse phonation and harsh barking cough. In case of laryngitis or croup, there is fever, inspiratory stridor, hoarse phonation في عنده صوته متضخم, and harsh barking cough. كحة قوية. If you see a patient with laryngitis or croup presenting to the emergency room, you would never forget the harsh barking sound and the hoarse phonation, مش قادر يحكي, صوته مبحوح على الآخر وبنفس الوقت عنده harsh barking cough. Croup associated with chest pain and sputum production, caused mostly by viruses, 90%, and we talk about laryngitis or croup, mostly we're talking about parainfluenza virus. Also, influenza and adenovirus can cause laryngitis or croup to a lesser extent. Respiratory syncytial virus, rhinovirus, coronaviruses all can cause, but it is mostly caused by parainfluenza virus. We can see also acute bacterial tracheitis, infection of the trachea, and there is pus purulent. Diagnosis, bacterial cause, we're going to do gram staining culture of the secretions obtained by direct laryngoscope, and we can also take blood sample for blood culture. Treatment is maintaining the airway open. Use also humidified air and oxygen, and in case of bacteria we might need to use antibiotics, but laryngitis and croup mostly are caused by viruses, and the treatment is going to be symptomatic. On the chest X-ray, due to narrowing of the airway, we're going to see what we call the steeple sign. So if we do an X-ray and we see the steeple sign اللي بتشبه الستيبل تبع الكنيسة, this is the steeple sign, we call it the steeple sign, then this is an indicative of laryngotracheal bronchitis or croup infection. Bronchitis and bronchiolitis, most of the time they spread from upper respiratory tract infection. They are characterized by fever, cough, sputum production, which is clear at the beginning and then it turns into virulent or become exudative. What are the predisposing factors to chronic bronchitis? Smoking for a long period of time, exposure to environmental pollutants, chronic infections such as infection with TB, tuberculosis, or in patients who have defective clearance mechanism of the secretion, such as in the cystic fibrosis patients. So in those patients, they might have chronic bronchitis. Acute bronchitis, patient present with persistent dry cough, rapid or noisy breathing, which we call wheezing. Patient also might have brief pause in breathing, توقف في التنفس لبضع ثواني, feeding less and having fewer wet nappies, vomiting after feeding, being irritable, and here we're talking about babies mostly. لما نحكي acute bronchitis بهذه الأعراض, they are mostly seen in infants and young children. ليش؟ لأنه عندك the airway passages are so small, so if they become infected, they are going to become edematous and they are going to cause further narrowing of the airways. Caused mostly by viruses, parainfluenza, influenza, adenovirus, and respiratory syncytial virus. It might cause to a lesser extent by bacteria such as Bordetella pertussis, Haemophilus influenza, Mycoplasma, and Chlamydia pneumonia. Chronic bronchitis. Chronic bronchitis, the cause of chronic bronchitis usually is endogenous, زي الأوتيتس media والsinusitis, وبالتالي the causative microorganisms, they are the same. اللي هم الستريب نيومونيا ونون تايبا بالهيموفيلس انفلونزا. Diagnosis in this case, we take nasopharyngeal specimens are used in direct fluorescence antibody and PCR assay to diagnose the viruses. For bacteria, we can do gram staining and culture and sensitivity. And the causative microorganisms might be mycoplasma and chlamydia pneumonia. Treatment in this case is humidified air and oxygen and specific antimicrobic therapy in case of bacterial infection. A number of infectious agents affect both the upper and lower respiratory tract region. Most well-known whooping cough, respiratory syncytial virus. Respiratory syncytial virus infect usually children and babies and causes bronchiolitis and bronchopneumonia. Causes bronchiolitis and bronchopneumonia. We have also the influenza virus, which might cause infection in the upper respiratory tract or lower respiratory tract. We have also the strep pneumonia, which might cause upper or lower respiratory tract infection as well. Pneumonia is infection of the lower respiratory tract, and we said there are multiple types of classification of pneumonia. Could be classified according to the anatomy. In the pneumonia, it's an inflammatory condition of the lung in which fluid fills the alveoli. So once the sterile environment of the lungs and alveoli is targeted by the bacteria, then this is going to lead to inflammation and filling of these air cavities by fluid. Can be caused by a wide variety of different microorganisms, either viruses, bacteria, or even fungi. Can be classified according to the anatomical position, whether lobar, segmental, interstitial. Also can be classified as community acquired or hospital acquired. Can be classified as typical or atypical according to the causative microorganisms in the typical or atypical. And usually pneumonia starts with an upper respiratory tract symptoms including runny nose and congestion. Headache is common in patients with pneumonia. Fever is often present in case of pneumonia, and the onset of lung symptoms follows the chest pain, fever, cough, and discolored sputum, maybe blood-tinged sputum due to rupture of small blood vessels within the alveoli. So the histological or the radiological lobar pneumonia versus bronchopneumonia, or lobar versus interstitial. When we say lobar, then infection is localized to a certain lobe of the lung. We know that the right lung has 3 lobes, while the left lung has 2 lobes because of the heart is occupying most of the space in the left lung. So if we say like infection in the right lower lobe, this is lobar pneumonia. When we say bronchopneumonia, when we look at the X-ray, we're going to see markings which are spread all over the lung, especially close to the bronchus. So this is called bronchopneumonia. Interstitial pneumonia, we're going to see these vascular markings within the lung tissue. Microbial can be classified as caused by bacterial, viral, or fungal. Clinical, atypical, or typical pneumonia. And in a moment, we're going to talk about the causes of typical and atypical pneumonia. Typical pneumonia is caused by bacteria 1, 2, 3, 4. Atypical is caused by 1, 2, 3, 4. Epidemiological, it's community acquired or nosocomial acquired. Community acquired, where the source of infection is within the community, spreading between patients or between the population. Nosocomial infection, where the patient is being admitted to the hospital and he acquires pneumonia from the hospital. All have clinical relevance, though no one is absolute. So you can never reach a diagnosis or reach the actual cause based on this. These are a way of classifying in order to classification of pneumonia in order to narrow the list of differential diagnoses, but reaching the diagnosis usually relies on the gram stain, culture, and sensitivity. Clinical presentation in case of pneumonia, we have cough, productive in case of typical pneumonia and non-productive in case of atypical pneumonia, fever, dyspnea or shortness of breath, general fatigue, headache, patient might have nausea, vomiting, or even in certain instances diarrhea, and he's going to have myalgia or muscle ache. Predisposing factors for pneumonia. So age plays an important role in determining the microorganism which is causing pneumonia. So microorganisms in children differ than those which are seen in adults. Also, COPD, chronic lung illnesses of the lung also play a role in the causative microorganism. Chronic illnesses such as diabetes, heart failure, immunocompromised status, alcoholism, smoking, and also the travel history, occupation of the patient. Those who are working with animals, working with birds, they are more prone to infections with atypical microorganisms. So all these play a role when you take a history from patient. You should take proper history, ask about all these in order to reach a diagnosis and try to narrow your list of differential for the causative microorganism. Physical signs in case of pneumonia, we have tachycardia, tachypnea. So there is increase in the heart rate, tachycardia, tachypnea, increase in the respiratory rate, hypotension, crepitation due to the presence of fluid within the lung and the alveoli. This is going to have crepitation. كيف لما تنفخ بمصاصة بالسائل. This is crepitation like. Bronchial breathing and fever. Usually when we hear by the stethoscope the lungs, there is smooth air entry, there is smooth breathing sounds. But once there is pneumonia, the lung becomes more stiff and the alveoli is filled with fluid. So if you try to hear with a stethoscope, you're going to hear the same as if you use the stethoscope to hear on the bronchi. So this is bronchial breathing, and we have fever as well. Investigation, chest X-ray, CBC, chest X-ray. We're going to see if the infection is localized to a lobe or segment, or it is bronchopneumonia or interstitial pneumonia. CBC, usually we're going to see increase in the white blood cells. C-reactive protein is going to be elevated because this is an acute phase reactant which is elevated in case of infections. We need to measure also the arterial blood gases, sputum culture, blood culture, and in case we think of viral infections, we need to do serological tests, PCR or antigen testing. Sorry, this is a normal chest X-ray, and you can see in the normal chest X-ray the air-filled cavities look black on the chest X-ray, and you can see the lungs are black, and the borders are well demarcated on the right and the left lung. Here in this chest X-ray, what we're seeing is bronchopneumonia, which are these markings close to the bronchus, and also interstitial pneumonia. Most probably this is caused by atypical pneumonia. In this case, the chest X-ray looks really worse compared to the physical presentation, or to the presentation of the patient and the physical examination of the patient. So the patient presents to you walking. That's why we call it sometimes atypical or walking pneumonia. The X-ray looks really bad, but the patient's condition is good. He comes to the clinic, he's walking, and his condition is not that bad, but the X-ray is worse. This is the presentation with atypical pneumonia. Here we can see this is right middle lobe pneumonia. So this is lobar pneumonia, right middle lobe. Here this is left lower lobe infection. So this is lobar pneumonia once again. What are the causes of pneumonia? Community-acquired pneumonia or typical pneumonia. Typical, atypical. Typical pneumonia or community-acquired pneumonia. Most common cause is strep pneumonia. We have also Haemophilus influenza and Staph aureus. The atypical causes of pneumonia, we have the chlamydia pneumonia, chlamydia psittaci, mycoplasma, coxiella, and legionella pneumonia. And all these bacteria lack the cell wall. And they cannot be treated with beta-lactam antibiotics. So they are treated with erythromycin tetracycline, erythromycin tetracycline, erythromycin, 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 and rifampicin. Here they are treated with beta-lactam antibiotics. Also, in addition to these types of bacteria, atypical viruses are considered a cause of atypical pneumonia. Typical, strep pneumonia, Haemophilus influenza, Staph aureus. Atypical viruses, chlamydia, mycoplasma, legionella, and coxiella. Community-acquired pneumonia are caused by strep pneumonia, Haemophilus influenza, Staph aureus, and Klebsiella pneumonia. Hospital-acquired pneumonia. In the hospital-acquired pneumonia, we tend to see infections with E. coli, with Pseudomonas, with Staph aureus, especially the MRSA, MRSA, methicillin-resistant Staph aureus. Pathogens, strep pneumonia, it's a gram-positive diblococci, almost all sensitive penicillin, cephalosporin, mostly sensitive to erythromycin. Haemophilus influenza, gram-negative coxobacilli, sensitive to amoxicillin, 25% produce beta-lactamase, and thus they are amoxicillin resistant, sensitive to coamoxiclav, cephalosporins, and ciprofloxacin. It is resistant to erythromycin. Staph aureus, usually seen after flu, cause severe necrotizing pneumonia in young adults. Treatment flucloxacillin and erythromycin. And in case of methicillin-resistant Staph aureus, we need to use vancomycin or linezolid. Atypical pneumonia caused by organisms that will not grow under routine culture conditions. There is non-productive cough. Negative culture. Clinical signs often do not match severity of a clinical and radiological presentation. Patient, another name for atypical walking pneumonia. The chest X-ray looks much more severe than the actual condition of the patient, as we said. Atypical pneumonia caused by Legionella, Mycoplasma, Chlamydia, and viruses. Also, we have another type of pneumonia, aspiration pneumonia, and aspiration pneumonia is seen in patients with abnormal gag reflex, such as those patients who have altered consciousness, bedridden, with CVA, aspiration pneumonia. So what we mean aspiration pneumonia? Aspiration pneumonia, the gastric contents get back through the esophagus and goes into the lung. And this is going to lead to chemical injury, acid injury, bronchial obstruction, and bacterial infection. Bacteria involved will reflect oropharyngeal flora, anaerobes and strep and Haemophilus, or gram-negative in the case of nosocomial infection. Treatment often broad-spectrum beta-lactamase, coamoxiclav or piperacillin, tazobactam, plus minus metronidazole because there might be anaerobes. Diagnosing atypical pneumonia, clinical picture. Laboratory culture not likely to be useful because they cannot be grown easily on culture, the atypical causes of pneumonia. Serology detect antibody response, but it usually takes time. Requires demonstration of a single high level or fourfold rise of the antibody titer. Antigen detection, it's a good strategy for Legionella, and we can also use PCR to detect the DNA or RNA of the organism. Potentially it's an excellent strategy, thus because it gives rapid results within a couple of hours. It's not available in every hospital, especially when we're talking about the public hospitals, but it is the method of choice in the future. And as we said, as we've seen in the COVID-19 pandemic, the PCR was the gold standard for diagnosis of COVID-19. So now the use of the PCR machines and the PCR kits to diagnose bacteria and viruses is becoming more common, and it is the future of the diagnosis. These are some of the microorganisms which cause infection in the respiratory tract and their drug of choice. So when we talk about strep pneumonia, we are talking about benzyl penicillin or amoxicillin, Staph aureus flucloxacillin, Legionella clarithromycin or ciprofloxacin, Q fever doxycycline, Mycoplasma clarithromycin, and Chlamydia pneumonia clarithromycin. Mycin. I think that's all for our lecture today. Thank you for listening, and if you have any question, do not hesitate to contact me on the Teams, and hopefully after 2 or 3 lectures we might, if you like, we might have a live session where you have gone over the lectures, and then we're going to have this live session for questions. Anyone who have questions might send me his question on Teams. If anyone is interested in a live session, please let me know, so that once you have studied the couple of lectures, we might have a live session to answer all your questions. And